picture this. You walk into a high-end cosmetic clinic. You've got the time, you have the recovery plan all mapped out, and you literally have thousands of dollars ready to pay for a procedure.
Right, you're totally prepared.
Exactly. You sit down with the surgeon, only to be turned away flat. And why? Because maybe your body mass index is a fraction of a point too low, or, and this is wild, because you used a nicotine patch 3 weeks ago.
Yeah, it shatters the illusion that reconstructive or cosmetic procedures are just, purely transactional. We are so culturally conditioned to view these interventions as off-the-shelf commodities.
Like ordering from a menu.
Exactly. But the biological gatekeeping for certain tissue modifications is, it's remarkably intense.
And that stringent gatekeeping is exactly what we are decoding today. So welcome to the Deep Dive. I'm your host, and I'm joined by our resident medical expert.
Hi, everyone. Great to be here.
Today, we are looking directly at the medical literature. And, we are synthesizing guidelines from the NHS, the British Association of Day Surgery, the International Society of Aesthetic Plastic Surgery, plus protocols from some of the top cosmetic gynecology clinics.
It's a very robust stack of sources.
It really is. And our mission today is to answer one central question. Who is the ideal candidate for labia majora augmentation?
Which is a question that forces us to basically strip away all the sensationalized tabloids. If you scroll through social media, you are bombarded with terms like designer vaginas.
Oh, right. That term is everywhere.
Yeah, and it implies this casual catalog-style customization of human anatomy. But the clinical reality is a strictly vetted, highly complex interaction between transferred biological material and the patient's existing vascular network.
Right, because you look at the media portrayal and it's framed purely as vanity. But diving into these clinical sources, the catalyst for seeking this out is overwhelmingly functional, isn't it?
Oh, absolutely.
We aren't going to spend time defining basic anatomy. You likely already know we are talking about the outer volume-bearing tissues of the vulva. But I was really struck by the underlying mechanics of why that tissue fails or deflates in the first place. What prompts someone to seek augmentation rather than the reductive procedure of a traditional labiaplasty?
Well, the structural integrity of that outer tissue relies heavily on a robust fat pad and a dense collagen matrix. It basically serves as a physiological shock absorber.
A shock absorber. I like that.
Yeah, and over time, that architecture degrades through several very natural mechanisms. Cellular senescence is the most common, which is really just a fancy way of saying cellular aging.
Yeah.
As we age, the adipocytes, the fat cells, they just lose their volume.
And hormones play a massive role there too, right?
They do. Add in the systemic drop in estrogen during menopause, and you get profound vaginal atrophy. The fibroblasts stop synthesizing collagen at the same rate, and the entire structural support network essentially just deflates.
But age and menopause aren't the only reasons. The sources also highlight significant mechanical trauma as a catalyst.
Right, like pregnancy.
Exactly. Pregnancy and vaginal childbirth don't just stretch the tissue, they can physically tear the underlying fascial support. Plus, there is an entire reconstructive tier to this that people rarely talk about.
Yeah, the clinical data includes patients repairing severe tissue fibrosis from gynecological radiotherapy.
Which is incredibly traumatic to the tissue.
It is. Or patients trying to rebuild localized architecture after chronic dermatological conditions, like lichen sclerosis, have completely obliterated the natural tissue.
So when that shock absorber is gone, the symptoms transition from just, aesthetic contour, changes directly into acute mechanical friction.
Exactly. Without that protective volume, the inner anatomy is subjected to constant shearing forces. The clinical literature actually documents patients suffering from severe microabrasions just from walking.
Just walking. Wow.
Walking, cycling, or even just wearing standard athletic clothing. The stratum corneum, the outermost layer of the skin in that area, it simply cannot withstand that level of unprotected friction.
Because it's not designed to bear the brunt of that mechanical stress. So, a patient is experiencing this real functional pain, and they seek out a solution to restore that barrier. So if a traditional labiaplasty is like tailoring a dress to remove excess fabric, labia majora augmentation is more like restuffing a favorite cushion that has lost its shape and support over the years.
That is a perfect analogy. And if the mechanical problem is a lack of volume, the sources present two distinct biological paths to rebuild it: dermal fillers or autologous fat transfer.
Right, let's break those down, starting with fillers.
So the filler route is heavily marketed under various industry terms like bikini fillers. But biologically, it relies on cross-linked hyaluronic acid. It is the exact same molecule used in facial fillers.
The same stuff people get in their lips or cheeks.
Exactly the same. It's prized because it acts as a powerful humectant. It binds to water molecules in the surrounding tissue, creating an immediate localized expansion.
So it's essentially injecting a microscopic sponge that draws in fluid to inflate the area. It sounds easy, minimal downtime. But looking at the literature, this presents a significant biological limitation for the patient, doesn't it?
It does, and the limitation is actually built into our own metabolic pathways. The human body naturally produces an enzyme called hyaluronidase.
Which breaks down the filler.
Precisely. It's designed to break down hyaluronic acid. Over the course of maybe 6 to 18 months, depending on the specific product and the patient's basal metabolic rate, those enzymes will completely degrade the filler.
So the volume just vanishes.
It vanishes, meaning the friction and discomfort return entirely unless the patient undergoes repeat injections, essentially indefinitely.
Which is a huge commitment, and I think that pushes a lot of candidates toward the second path, which the sources call the surgical gold standard for permanent volume restoration fat grafting.
Right, autologous fat transfer.
Yeah, so you are harvesting your own fat tissue from the abdomen or flanks via microliposuction and relocating it. But the preparation of that fat before it's injected is fascinating to me.
Oh, the centrifugation process.
Yes. The clinical protocols detailed the specific process. I always assumed spinning the fat just, cleaned it. But it's actually a rigorous physics application to isolate cellular density, isn't it?
It is. It relies entirely on G-forces separating materials by specific gravity. When the surgeon harvests the tissue, it's this chaotic mixture. You've got intact fat cells, tumescent numbing fluid, blood, and the free lipids, which is the oil from fat cells that ruptured during the liposuction.
Sounds messy.
It is. But spinning that mixture in a centrifuge forces it into distinct stratified layers. The heavy blood and fluids sink to the bottom. The free oils float to the very top. And what remains perfectly suspended right in the middle is the pure, viable adipose tissue.
And here is where the clinical sources completely broke my mental model of what fat actually is. Because I always pictured fat as just, inner energy storage, basically biological bubble wrap.
Most people do.
Right. But the clinics specifically highlight that this purified middle layer contains something called the stromal vascular fraction.
Yes, the SVF. This is the primary reason autologous fat transfer is considered regenerative medicine, not just cosmetic volume replacement.
Wait, regenerative, like it actually heals the tissue?
Exactly. Adipose tissue is one of the richest sources of mesenchymal stem cells in the adult human body.
Wow.
Yeah, so when you transfer that purified fat, you are packing the deflated tissue with these multipotent stem cells alongside endothelial precursor cells and a massive array of growth factors.
So the injected material isn't just sitting there, it's actively communicating with the surrounding damaged tissue.
It acts as a biological signaling center. Those stem cells release vascular endothelial growth factor, which commands the local tissue to start generating new capillary networks.
That's incredible.
And they signal the dormant fibroblasts to ramp up collagen and elastin production. In patients with severe radiation scarring, the SVF has actually been shown to actively break down rigid fibrotic bands and replace them with healthy, pliable tissue.
That regenerative capability is amazing. But, okay, I have to bring up a glaring paradox I found across multiple surgical guidelines.
I think I know where you're going with this.
Probably. Because in one breath, the medical literature advertises fat grafting as permanent. But in the very next sentence, the surgical protocols explicitly state that 30 to 50% of the transferred fat will be reabsorbed and flushed away by the body within the first few months.
Yeah, you are identifying the most critical biological hurdle of the entire procedure right there.
It just seems like a massive contradiction to me. I mean, how can surgeons promise a permanent functional repair if they know going in that up to half the structural material is going to simply vanish?
Well, it comes down to the brutal reality of tissue relocation. When the surgeon injects those isolated adipocytes into the labia majora, those cells are entirely disconnected from any vascular network.
They have no blood supply.
None. They have no oxygen supply. They are dropped into a hypoxic environment, and they are essentially holding their breath.
It's like airdropping a battalion of soldiers deep behind enemy lines without a supply chain. I mean, they have a very narrow window to build roads back to the main base before they run out of rations and starve.
That is the exact biological mechanism at play. The race is between angiogenesis, which is the body's frantic effort to grow new microscopic blood vessels to reach the graft, and cellular starvation.
And sometimes the starvation wins.
Often it does. The historical data shows us that universally, 30 to 50% of those fat cells lose the race. They succumb to hypoxia before the new capillaries can reach them.
They just die off.
Right, and then the body's macrophages recognize them as dead cellular debris and safely metabolize them.
So the surgeon actually has to calculate that biological tax into the blueprint of the surgery. They purposefully overcorrect, packing in excess volume, knowing the localized starvation will shrink it down to the target size.
Exactly. The permanence applies to the survivors. The 50 to 70% of the cells that successfully bridge that vascular connection are now living, fully integrated tissue. They are permanently wired into the labia's blood supply.
And that biological tightrope ensuring those cells survive is exactly why the physical profile of the ideal candidate is so ruthlessly strict.
Yes, it is.
I mean, if you choose the temporary filler, the gatekeeping is minimal. But for a fat transfer, the screening process we found in these medical protocols reads like an elite athletic physical.
It really does. The baseline, of course, is age and systemic health. The absolute minimum age is 18. And that's anchored in the physiological reality that the vulvar tissue continues to develop and mature through the late stages of puberty.
Right. Intervening in an incomplete developmental process is scientifically and ethically unviable. And the systemic health requirements are where the British Association of Day Surgery, or BAYDAYS, really draws a hard line. Their protocols dictate that if a patient has any severe cardiorespiratory disease or any systemic condition that disqualifies them from standard day case surgery, they are completely disqualified from this.
Because the physiological pull of surgery is profound. The sympathetic nervous system stress response to anesthesia and tissue trauma just far outweighs any functional reconstructive benefit for those patients.
Right. But the more unique criteria actually stem directly from the mechanics of the graft itself, like BMI. A patient must pass a specific body mass index threshold, not to ensure they are thin, but to ensure they possess enough excess subcutaneous fat to harvest in the first place.
Which is an ironic barrier to entry if you think about it. If a patient's BMI is very low, maybe due to the extreme athletic training that caused their severe chafing to begin with, they are mathematically disqualified.
You cannot rebuild the architecture if you don't bring your own bricks to the site.
Exactly. And beyond just possessing the tissue, the metabolic stability of the patient is paramount. The medical guidelines insist on a highly stable, sustainable weight prior to surgery.
And that ties back to how adipocytes function in adults, doesn't it? Because fat cells don't actually multiply in adults. They just expand and contract.
Right. Cellular hyperplasia, the creation of new fat cells, is incredibly rare in adulthood. Instead, we see cellular hypertrophy. The existing cells expand their lipid storage capacity when caloric intake exceeds expenditure, and they shrink when in a deficit.
Okay, so because those transferred cells are now permanently vascularized in the labia, they remain metabolically active.
Yes, they will respond to systemic, hormonal, and metabolic cues exactly as they did when they lived on the abdomen or the flanks.
Wow, that paints a fascinating picture of the postoperative reality. I mean, if the patient gains 20 pounds a year after the surgery, the adipocytes in the augmented tissue will undergo hypertrophy.
Right, they will swell.
So the area could become overly bulky, creating a new source of mechanical friction. And conversely, if they experience massive weight loss, those cells will shrink, deflating the tissue and instantly undoing the surgical repair.
The physical architecture is entirely tethered to the patient's ongoing metabolic stability. And, the same logic applies to the strict protocols regarding family planning.
Right. The guidelines stipulate the ideal candidate has completed their family.
Because introducing the massive hormonal shifts of pregnancy, the influx of the hormone relaxin that destabilizes connective tissue.
Not to mention the sheer mechanical stretching of childbirth.
Exactly. All of that would obliterate the newly integrated fat matrix. The patient would essentially be tearing down the internal scaffolding they just spent months carefully integrating.
It makes total sense when you look at the mechanics. But out of all the physical criteria, the one that the clinic protocols highlighted with absolute non-negotiable urgency was the nicotine rule.
Oh, yes. The nicotine rule is absolute.
A candidate must be a strict non-smoker, requiring the cessation of all nicotine products, vapes, patches, gums, for at least 4 weeks before and 4 weeks after surgery. Now, we generally accept that smoking impairs healing, but the literature treats nicotine like absolute poison for this specific procedure.
You have to look at how nicotine manipulates the vascular system on a microscopic level. Nicotine aggressively binds to the nicotinic acetylcholine receptors in the nervous system, triggering a massive release of catecholamines.
And that does what exactly?
It forces peripheral blood vessels to clamp down and constrict.
So it's a potent vasoconstrictor.
Yeah.
So going back to our airdrop metaphor, if the transferred fat cells are in a desperate race against hypoxia, waiting for new capillaries to reach them?
Nicotine actively destroys the supply lines. Vasoconstriction shuts down microcirculation. Angiogenesis, the sprouting of those life-saving new blood vessels we talked about, is severely stunted or halted altogether.
So the surrounding tissue simply cannot deliver oxygen to the graft.
Exactly. Which means the 30 to 50% biological tax we discussed earlier skyrockets. The cells don't just shrink, they starve to death en masse.
Which causes what the sources call massive fat necrosis, right?
Yes. When large clusters of adipocytes die simultaneously, the body's macrophage system is completely overwhelmed. It cannot clear the dead lipids fast enough.
And what happens to the lipids?
Those lipids saponify. They essentially turn into hard, calcified, palpable nodules deep within the tissue.
Oh, wow. That sounds awful.
It creates severe localized pain, invites opportunistic infections, and completely ruins the structural repair. Nicotine practically guarantees the graft will fail, which is why surgeons enforce that zero-tolerance policy.
So assuming a patient navigates this physical gauntlet, they are metabolically stable, they have harvestable donor tissue, their cardiorespiratory system is robust, and they haven't allowed a single molecule of nicotine into their bloodstream for a month.
They're still not at the finish line.
Right, they still have to pass the psychological screening. The clinical literature spends an extraordinary amount of time detailing the required mindset of the ideal candidate.
Because the psychological screening focuses heavily on managing the physiological reality of the graft. The primary requirement is a fundamental understanding that the human body is inherently asymmetrical, and surgery cannot override that biology.
So a patient expecting absolute, mirrored, millimeter perfection is disqualified.
Immediately, because the reabsorption process we discussed is chaotic. If the body metabolizes 35% of the graft on the left side, but 45% on the right side due to microscopic variances in local vascularity, the result will have slight asymmetry.
It's just out of the surgeon's hands at that point.
Exactly. The ideal candidate accepts this biological unpredictability, understanding they are seeking functional improvement, not the precision of a machined part.
Though the clinical notes do mention that if a patient is deeply distressed by minor post-surgical asymmetry once the graft has fully settled, a surgeon might utilize a microscopic touch-up of hyaluronic acid filler to balance the visual contour. But the core motivation for the surgery cannot be driven by external perfectionism.
The International Society of Aesthetic Plastic Surgery guidelines are unequivocal on this. There is no baseline normal for vulvar anatomy.
Right.
If a patient's motivation is driven by dysmorphia or an attempt to conform to a hyper-edited, popularized media aesthetic, reputable clinics will decline to operate.
And the data strongly corroborates that. The patients reporting the highest satisfaction rates, and the studies show satisfaction hovering well over 90%, are the ones who sought the procedure to resolve their own physical friction.
Yeah, it's the patient who just wants to be able to sit on a bicycle seat without wincing.
Or who wants to move through their day without the acute mental distraction of physical chafing? I mean, it sounds like the ideal candidate isn't trying to turn their body into a filtered photograph. They're treating this like taking a beloved, worn-out pair of shoes to a master cobbler.
That's a great way to put it.
It's about restoring function, comfort, and personal confidence so they can just walk through life without thinking about it.
The ideal candidate views the intervention as an act of personal restoration. They are utilizing surgical tools to remove a daily physical barrier, allowing them to simply exist comfortably within their own anatomy.
So stepping back and looking at the composite profile we've built from all these medical sources today, the ideal candidate for labia majora augmentation is incredibly specific.
Very specific.
We're talking about an adult with robust systemic health and metabolic stability, possessing enough harvestable donor tissue to facilitate a transfer. They must maintain a strict zero-nicotine lifestyle to ensure microvascular survival. And most crucially, their motivations are entirely intrinsic, seeking to repair the natural volume loss or mechanical trauma that is actively impeding their daily quality of life.
And, the rigorous nature of these protocols serves as a powerful reminder of the stakes involved. The medical community enforces these boundaries to ensure that the complex biology of tissue transfer ultimately serves the patient's functional well-being rather than compromising it.
It completely dismantles the casual narrative surrounding these procedures, really grounding the reality in cellular survival and structural physics. But I want to leave you, the listener, with a final thought to ponder based on the mechanics of what we've unpacked today.
Let's hear it.
We established that the surviving adipocytes from a fat graft permanently integrate into the labia's vascular network. They remain living, metabolically active cells. They will expand if your caloric intake shifts, they will shrink if you enter a deficit, and they will undergo cellular senescence as your systemic hormone levels change over the decades.
Right, they act like normal fat.
Exactly. This means the surgical outcome is never truly finished when the incisions heal. The baton is continuously passed back to the patient. So doesn't this biological reality suggest that your future stress levels, your metabolic health, and your overall cellular environment essentially make you an active, lifelong co-sculptor of your own anatomical repair?
That is a fascinating way to frame it. The architecture may be designed in the operating room, but it is maintained by the biological environment you cultivate every day afterward.
The gatekeeping doesn't stop at the clinic door. The standard is written into the surviving cells. Keep examining the underlying mechanics of the world around you, keep looking past the sensational headlines, and keep exploring the incredible biological intersections of medicine and personal physiology. Thanks for joining us on this deep dive.